But that's the way science ought to be done.
We have 15 people in that study through the foundation.
That's fantastic.
They will get the procedure done within a year if they get the sham.
Yeah, that's right. There's a crossover. And most trials, I think that's an important point to make, Steve. Most of these trials that are randomized controlled trials, they provide what's called a crossover arm. That means that if at any point during the trial, the researchers discover that the benefit is so much greater in the experimental group versus the patients who didn't get the experimental group, they are allowed to automatically cross over to the experimental group and get the procedure done, which I think is a very nice, that's the way science really ought to be done in terms of randomized controlled trials. And the other one is Gary Siskin's, they're going to recruit a significantly larger number of patients than the 20 or so patients that Buffalo started out looking at, and they have started enrolling. The big trial that hasn't really started enrolling yet, that's due to start enrolling soon, is the Italian trial, the Brave Dreams trial that Dr. Zamboni's going to run, and that's going to be an attempt to duplicate his work with the original 65 patients in a much bigger population of 600 plus patients. So these are the kind of trials that we need to get done. Most of these are years in terms of how long you go from start to finish. So we're not talking about tomorrow, but we are talking about sometime in the relatively near future. So moving from the data and talking about what we do know and what science we do have to how do we treat CCSVI now. I'm going to talk a little bit about the diagnostic testing that we use to look for CCSVI, and then I'll talk a little bit about treatment, and then I'll show you the vignette so you have an idea of how this whole thing comes together. The three diagnostic imaging modalities that are available right now to look for CCSVI are Doppler ultrasound, magnetic resonance venography, or MRV, and catheter venography. Doppler ultrasound really has taken the lead as the protocol that most people are using to screen for CCSVI, to look for abnormal veins. Doppler ultrasound is a technique where we use what's called grayscale imaging. That's the typical kind of snowstorm images that you've seen pictures of. That's the anatomy. That's looking at the anatomy and the actual structure of the veins. The Doppler part of the examination is how we look at the blood flow within those veins. And the Doppler part of this examination, all of you have experienced the Doppler phenomenon in your normal daily lives and are probably not aware of it. But the way the Doppler technique works is it bounces sound waves off of the blood cells and then looks at how fast those sound waves come back. If you've ever heard an ambulance or a police car coming down the road and it's coming toward you and then it goes right by you and you notice a change in the frequency of the sound that the siren's making, that's the Doppler effect. It's because the sound waves, basically the frequency changes as they come closer to you and then move further away from you. That's the principle that we use to look at red blood cells to tell us how fast they're flowing and what direction they're flowing in. So the parameters that we look at with Doppler ultrasonography is flow. We look for reflux. Reflux means flow in the wrong direction. Stasis, flow that isn't progressing, flow that's sitting still. The direction and the phasicity of flow, that means that flow will change with the person's respiration. And that phasicity is a normal thing that we look for when there's no blockage between the lungs and the jugular veins. We also look at the actual appearance of the veins. We're looking for blood clots or thrombus. We're looking for narrowing or stenosis. And we're looking for septum, flaps, or annulus. Annulus, someone was asking me before the talk started about these valves that they've heard about that are sort of ring-shaped valves as opposed to normal flap valves. That's the annulus that we're talking about. And you can picture it like a membrane. It's a membrane with a hole in the middle instead of a flap valve. That's an annulus. And then we also look at physiology. And ultrasound allows us to look to determine whether or not the jugular veins collapse appropriately when we change position. It's one of the only modalities right now that you can actually look in two different positions. We really can't do it with any other modality. There's an MRI machine being worked on right now that will allow patients to be tipped into an upright position, but it doesn't exist for general use at present. There are a lot of benefits for Doppler ultrasound. The biggest one is that it's non-invasive. Patients are not exposed to radiation. They're not exposed to high frequency, high magnetic fields. They're not exposed to contrast. It's low cost. The cost is the cost of having the technologist do the procedure. It's very available. Obviously, just about every vascular lab has an ultrasound at their disposal, and it's widely applicable. It really, at any level of debilitation, a patient can still have an ultrasound done. It allows us to change a patient's position. So a lot of benefits. The drawbacks are it's very difficult to do, as Steve sort of inferred before. If you're not using the appropriate Zamboni criteria, it's a difficult procedure to get any real good information out of, so it's operator dependent. The people doing the ultrasound really need to be trained to look for what they're supposed to be looking for. And unfortunately, there's only one paper out there. There's a paper that Dr. Zavadinov presented that looked at the comparison of ultrasound and venography, but there isn't a lot of good validation between ultrasound and venography, and that's an important thing because the gold standard is still venogram. And what that means is that if you see an abnormal ultrasound, if it's positive, you're probably going to find an abnormality when you do the venogram, but if it's negative, it's hard to know what you're going to find, and most people still proceed to venography because it's the gold standard. It's the way to really look to see if there's an abnormality there. So what are the Zamboni criteria for looking at ultrasound? Everyone hears about these Zamboni criteria. They're really pretty simple. There are 5 of them, and these are what they are. Criteria number 1 is reflux, or flow in the wrong direction in either the jugular vein or the vertebral veins. Criteria number 2 is bidirectional flow. That means flow in to and fro flow in the veins of the central nervous system within the skull, so intracranial veins and sinuses. Criteria number 3 is a narrowing, or IJV stenosis. That's narrowing in the internal jugular vein. Criteria number 4 is an absence of detectable flow. So we look at we put an ultrasound with a Doppler on the jugular vein, and we don't see any flow. The sound waves don't bounce off of any moving red blood cells. And then criteria number 5, this is the one that's a little harder to explain, but I think the diagram that I showed you earlier of the change in the size of the veins when the patient goes from laying on their back to an upright position, that's called the cross-sectional area of the vein. And that should be a positive number. Basically, when the person goes from laying down to upright, and you subtract those 2 numbers out, it should be positive. If that number is negative, in other words, the vein gets bigger when you go from laying down to upright, it's a negative delta, a negative change in the CSA, and it means that the vein's not acting appropriately. Does that make sense? It's an important point because that's actually one of the criteria that's most often present in patients with CCSVI. These criteria were boiled down a little bit and simplified at the ISNVD, the International Society of Neurovascular Disease meeting in Bologna in March of 2011. And basically what they did was eliminate, by consensus, looking for the veins within the intracranial part of the circulation because it's just too hard a part of the exam to do effectively. And they found that if they used these 4 and still looked for 2 of the criteria being positive to call it CCSVI, they would get a similar number of positive hits. In other words, their sensitivity would be similar. So in either one of these criteria, the idea is you have to have at least 2 of them present for you to have CCSVI. It doesn't matter which one it is, but you have to have at least 2 of them present. And these are some ultrasound examples. So you can see why I say they look like a snowstorm. This upper panel here, where the red dot is located right now, that's the jugular vein. And you're looking at it sort of like a slice from a loaf of bread, transverse plane going down the patient's neck. So the jugular vein right next door is the carotid artery. And when we put the color Doppler on that, you can see that the color is opposite between those 2 blood vessels. Thanks. So the jugular vein is blue and the carotid artery is red. And this scale on the side tells us that these are 2 different directions. If those 2 colors match, if they're both blue or they're both red, it really doesn't matter because you can assign the color however you want to. But if they're both the same color, it means the flow in the jugular vein is in the wrong direction because blood flow won't be in the wrong direction in the carotid artery in a human. Okay? So that's important. That's why color Doppler is so important. And if you look at it in the longitudinal plane or kind of looking down the length of the patient's neck, you can see that these ultrasound images, high-resolution ultrasound, will show us pictures of the valves. You can see here this little fine, I think you can see this little fine linear structure here. Those are the valves, and we can determine how well they're functioning real time. When we look at these for real, when we're looking at these ultrasounds, in the lab, it's a moving picture. It's constantly moving. They're not snapshots. This is real-time imaging and allows us to actually look at the flow. And this is abnormal flow, actually. If you look at this, this is all jugular vein, and you can see how there's flow in both directions. There's flow down the jugular vein and back up the jugular vein. That's reflux. That's an abnormal jugular vein, and that represents one of the criteria being positive. Okay? So what about MRV? Well, MRV has its place. MRV, magnetic resonance venography, is much more complicated than ultrasound to explain. The physics of it are beyond my ability to put into any kind of nutshell. Suffice it to say, it's very, very good at looking at differences between different kinds of tissue and at looking at the flow within the different kinds of tissue. And if the sequences are done appropriately, in other words, if the procedure is protocoled appropriately, then you can get a lot of information about the patient's jugular veins. The problem is the way that you generate this protocol totally dictates what images are created, what images come out. And if you're having the standard magnetic resonance imaging done that most patients with a neurodegenerative disease like MS have, it's not done to look for the veins. It's not done to look for the arteries, and it will give us essentially no information about the flow in those blood vessels. So that is an answer to the question that we often get from patients who say, I had an MRI last year, I had an MRI this year, can't you just look at that MRI and see if I had CCSVI? The answer is no. If the MRI wasn't done specifically to look at the veins, And I mean the veins. It can't even be done specifically to look at the blood vessels, because most MR studies to look at blood vessels are done to look at arteries. And so if you do an MR study and don't appropriately post-process it or time it, this is what you get. And this is very hard for anybody to interpret, never mind a radiologist. This is an overlay of all the vascular structures between the head and the neck. If it's appropriately sequenced and then post-processed so that all of the arteries get subtracted out, you can get a very beautiful image of the veins and get a lot of three-dimensional anatomic information about the veins. But this is a lot of effort and a lot of expense, frankly, to get the appropriate examination done, and that's the real problem. The real problem in my mind isn't that MRV it's a wonderful way to look at the veins when you appropriately protocol it and you appropriately post-process it, but it's a very expensive way to look at the veins. And most insurers, at least in the US, and I don't have as much understanding of the way the Canadian system works, but most of the insurers in the United States would flatly refuse doing an MRV to look for CCSVI at this point in time. Hopefully that'll change, and then maybe we can get MRVs on a lot more patients, but right now that's the situation. What's that? Yeah, you can't even, it's not even a consideration, right.
No,
Well,
one of those machines in Quebec City, another one in Manitoba, Winnipeg, and another one of them in British Columbia.
Yep.
So they can do it, but like you said, it's a cost.
Yep, I think the cost is the big issue, and frankly the expertise, because people who are used to looking at, people who are nervous system radiologists, neuroradiologists, are very, very good at looking at neuroradiology, the solid organ part of the nervous system. But at least in my practice and in a lot of other practices, all of the MRA part of things, as far as looking at the blood vessels, that's our job. That's what interventional radiologists do. So frankly, even having the equipment, you still have to have the expertise to do it. So it's got some hurdles to get by. Having said that, I think it's important to point out that there is the Hackey protocol, which some of you have heard about. The protocol is amazing. Some of the information that protocol gives in terms of who should be treated versus who shouldn't be treated. You get to look at both veins simultaneously. You can determine from those studies as to whether or not the flow in one vein being treated is going to have a negative effect on the other vein. They're really wonderful, wonderful studies, but unfortunately there's just no way to apply them to the number of patients they would need to be applied to use this as right now as a useful technique. Catheter venography is the gold standard. Catheter venography has been done to look at the veins. It's the first way that radiologists and imagers were used to look at veins in any part of the body. It's still the gold standard in terms of when you don't know and you need to prove one way or another, catheter venography is the way to look. Probably the most important thing about it from a patient standpoint is that it's safe. We know it's safe. Before CTs, before ultrasound, before MRV ever came along, thousands and thousands of these things were done all around the world to look at veins. It was the only way to look at veins. From our standpoint, one of the things that's most important about it is that it allows us to treat at the same setting that we do the catheter venography. Okay? So if you have any of the other studies done,